In terms of the baseline cardiovascular disease, in terms of patient teaching, it is very important, for nurses to teach the patient aggressive management of the known cardiac risk factors, such as I mentioned, hypertension, hyperlipidemia, and diabetes, because these are the ones that could cause cardiovascular complications later on when patients are receiving anti-cancer treatments.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS, and today we're talking with Anecita Fadol, Associate Professor at the University of Texas MD Anderson Cancer Center, about symptom management for the cardiovascular complications associated with today's cancer treatments. You can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Anecita.
Thank you for inviting me to speak with you today, Jaime.
Wonderful. Well, to kick things off, let's start at the beginning. What are some of the most common cardiovascular complications that we are typically seeing with cancer treatments that are in use today?
The most commonly reported cardiovascular toxicities can be classified into the main 5 categories. 1, cancer treatment-induced hypertension. 2, cardiomyopathy, left ventricular dysfunction, or heart failure. 3, myocarditis. 4, vascular toxicity. And 5, arrhythmias and QTc prolongation. These cardiovascular toxicities can be caused by the different anti-cancer agents.
So let's explore that a little bit more. How do these cancer treatments affect the heart and the cardiovascular system?
The cancer therapies, a variety of them, have a significant impact on the cardiovascular system, which can adversely affect cardiac structure and or function. The effects of these different anti-cancer agents or treatments can result in endothelial damage, vasospasm, platelet activation and or aggregation, and attraction of the elevated LDL cholesterol particles. These effects on the cardiovascular system is collectively termed cancer therapy-related cardiac dysfunction, or sometimes it's just referred to in articles as CTR-CD. Each of these effects, not all cannot be found in just one cancer treatment, but each or different cancer treatments or therapies such as chemotherapy or immune checkpoint inhibitors may have the mechanism that I just mentioned that can affect the cardiovascular system.
So as we look into each category and then each individual side effect, can you help describe the symptoms that these cancer therapy-related cardiovascular complications, how they will present and how nurses might identify these through assessment?
The symptoms of these cancer therapy-related cardiovascular complications will vary depending on types of the anti-cancer agents, as well as the patient-related factors, such as the pre-existing comorbidities that patients have before receiving these treatments. But the most common symptoms of a potential heart issue related to cardiotoxicity may include chest pain or chest pressure, palpitations, extreme fatigue, shortness of breath, bilateral lower extremity edema, and sometimes including the abdomen, orthopnea, paroxysmal nocturnal dyspnea, or rapid changes in weight. So these symptoms may not be present in one single cardiovascular complication, meaning these are dependent on the type of the anti-cancer agent that the patient has received. But the most commonly identified symptoms with a potential heart issue related to cardiotoxicity are, as I mentioned. So I listed them according to, urgency. And the one that needs urgent attention is chest pain or chest pressure. The cancer patients are often at risk for cardiovascular mortality and morbidity, given the shared risk factors between cancer and cardiovascular disease. Also, there are certain anti-cancer therapies that are associated with the increased risk of cardiovascular events. And this can persist for weeks or even years after treatment. Therefore, chest pain or chest pressure is a symptom that should not be ignored in cancer patients as well as survivors. There are several different potential causes of chest pain in a cancer patient. And this chest pain may indicate acute coronary syndromes, myocarditis, pericarditis or pericardial effusion, valvular heart disease, and chest pain can also be manifested in some of the non-cardiac conditions such as pulmonary embolism, pneumonitis, or malignant pleural effusion. So in terms of the potential causes of these chest pains in acute coronary syndromes, this can be resulting from coronary vasospasm, which can result from anti-cancer agents such as fluoropyrimidines, taxanes, tyrosine kinase inhibitors, or alkylating agents. The acute coronary syndrome also can result from coronary thrombosis and can be secondary to medications, anti-cancer agents such as cisplatin, VEGF, or vascular endothelial growth factor inhibitors. And sometimes, the presence of a malignancy can result into a coronary thrombosis because, as we know, patients with cancer has a hypercoagulable state. In patients receiving radiotherapy, tyrosine kinase inhibitors, immune checkpoint inhibitors, and hormone therapy, like as in cases of patients with prostate cancer, these anti-cancer treatments can cause accelerated atherosclerosis, which can lead to acute coronary syndromes. And in certain cases, a tumor compression secondary to a primary tumor or metastasis can have chest pains, which resulting from these acute coronary syndromes. Another most common complication or cardiovascular event that would make you think of when patients has chest pains is myocarditis. Given that there's an increased indication now for immune checkpoint inhibitors, myocarditis is a complication that can occur. It is very rare. The incidence is about 0.5 to 1.4%, but the mortality rate is greater than 50%. So therefore, it is important that the etiology of chest pain is recognized in terms of these myocarditis. It can also result from the CAR T cell therapy, they can have myocarditis, but it's not as very common. In terms of chest pain resulting from pericarditis or pericardial effusion, they can be caused by radiotherapy, meaning in the acute phase, patients can have inflammation in the pericardium or pericarditis, which can cause chest pains or manifest as chest pains. Anthracyclines, very rare, but patients can have pericarditis and have chest pains, as well as taxanes and alkylating agents. In patients with valvular heart disease, secondary to infective endocarditis or non-bacterial embolic endocarditis can manifest also as having chest pain. The other symptom I mentioned earlier is palpitations. Palpitations is a symptom frequently seen in patients on atrial fibrillation. And in patients with cancer, this usually occurs while patient is receiving anti-cancer medications such as ibrutinib, which is a Bruton kinase or a BTK inhibitor used in a variety of B-cell lymphomas. Ibrutinib is estimated to cause atrial fibrillation in about 6 to 16% of patients. Another symptom that I discuss is extreme fatigue, shortness of breath, bilateral lower extremity edema, and sometimes including the abdomen, orthopnea, paroxysmal nocturnal dyspnea, and rapid changes in weight. These are the symptoms that are usually associated with cardiomyopathy, chemotherapy-induced cardiomyopathy, left ventricular dysfunction, or heart failure. Extreme fatigue is a symptom that should really be investigated when a patient is complaining of that, because fatigue is a common symptom in patients with cancer as a result of chemotherapy while they're receiving radiation therapy, immune checkpoint inhibitors. So fatigue is a common symptom, but in many cases, because of the presence of cardiovascular complications such as heart failure or left ventricular dysfunction, then the fatigue is more severe. The main etiology of that fatigue can be ruled out with differential diagnosis using different diagnostic testing. So in patients, I mentioned, shortness of breath, bilateral lower extremity edema, orthopnea, and paroxysmal nocturnal dyspnea are some of the other symptoms that, when associated with fatigue, can make you think that the patient may have cardiomyopathy, left ventricular dysfunction, or heart failure. So with vascular toxicity, the different medications or anti-cancer treatments can also lead to vascular toxicity. And the asymptomatic ones, they may be manifested as coronary artery disease, patients with peripheral artery disease, carotid artery disease, which in these three that I mentioned can be resulting from radiation therapy. Because in those patients who had radiation therapy, which involves the heart in the radiation field, can have accelerated atherosclerosis. And then you can have the venous thrombosis and arterial thrombosis, which are also resulting from some anti-cancer agents. In the symptomatic vascular toxicity, patients may manifest as having a stroke, a TIE, an acute heart attack, and in certain cases, symptomatic with peripheral artery disease may lose their pulse, or they may have purplish discoloration of the lower extremities. So hypertension in the cancer patient is different from the hypertension in a general population, because in a cancer patient, this presents a unique situation in which hypertension may be temporary and it may be due to the cancer treatment, but with more abrupt onset that can lead to end organ damage and other complications if not controlled. So in a patient with cancer, hypertension is defined as an elevation of systolic or diastolic blood pressure after the initiation of cancer therapy without any contributing changes. According to the CTCAE criteria for hypertension, it is divided into 4 grades. In the patient with cancer, the most common causes are the chemotherapeutic agents, which include several of the angiogenesis inhibitors, commonly known as vascular signaling pathway or VSP inhibitors. This includes antivascular endothelial growth factor, such as bevacizumab or Avastin. Certain tyrosine kinase inhibitors, such as sunitinib, sorafenib, and pazopanib. Also, in patients who undergo surgery or radiation therapy that involves the head and neck, can lead to a baroreflex failure, resulting in labile hypertension or hypertensive crisis. These are difficult to treat and challenged to manage. These patients with hypertensive crisis secondary to radiation therapy, especially if they are continuing the radiation treatment. In terms of the mechanism of hypertension in cancer patients, there are several theories about the cancer treatment-induced hypertension, including endothelial dysfunction associated with reduced nitric oxide bioavailability, increased vascular and renal endothelin production, increase in vascular tone, vascular rarefaction, which is a decrease in the density of the microvessels, and renal thrombotic microangiopathy, with secondary glomerular structure and functional changes that leads to proteinuria and hypertension. So how do we manage hypertension in a patient with cancer? The management right now is based on the JNC7, but the one that is most frequently used also is based on the recommendations of the expert panel of the Investigational Drug Steering Committee of the National Cancer Institute. These recommendations are in regard to the evaluation, surveillance, and management of blood pressure problems in patients receiving VSP inhibitors. So these recommendations are: 1, stratification of patient risk at baseline. Make sure that if patients are receiving VSP inhibitors, take the blood pressure at baseline. Pre-existing hypertension is common in cancer patients and should be identified and treated before initiation of the VSP inhibitors. It's because if it is not controlled prior to initiation of therapy, the blood pressure can go so high. The second recommendation is active monitoring of blood pressure throughout the period of cancer management, especially during the first cycle of therapy, when most patients experience a secondary elevation in blood pressure. The third recommendation is the target for blood pressure management should match the JNC7 classification. Now it's JNC8, and guidelines with a target blood pressure below 140/90 millimeters of mercury in general and below 130/80 millimeters of mercury in patients who have diabetes mellitus or kidney disease. The fourth recommendation is aggressive blood pressure control is advised to minimize the risk of end organ damage. And the fifth recommendation is attention to the choice of antihypertensive medications. The panel recommends referral of patients to hypertension specialists whenever oncologists face difficulties in achieving adequate blood pressure control. One thing I'd like to comment, from the nursing standpoint in terms of management of hypertension, patients need to be advised that to monitor the blood pressure continuously while they're receiving the VSP inhibitors. And if, the VSP inhibitor is discontinued, make sure that they contact the provider that these blood pressure medications should be titrated down also. Because there are cases wherein the patients present in the emergency room because they passed out, because they're so hypotensive, because after the anti-cancer agent is discontinued, they're still continuing with their blood pressure medication. The other cardiovascular complication or issue in patients with cancer, arrhythmias and QT prolongation. There are several factors that can cause QT prolongations in patients with cancer. Anti-cancer drugs is one of them, like arsenic trioxide, ceritinib, crizotinib, dasatinib, all those IBs. Number two is the coexisting factors. Like among the non-cardiac coexisting factors or comorbidity is like hypothyroidism. And there are some patients with congenital long QT syndrome, as well as in patients with left ventricular dysfunction, as well as myocardial ischemia. Another cause of acute prolongations in patients with cancer are the concomitant treatments that the cancer patient is treated. For example, patients receiving antidepressants, antiemetics, it's very common, such as Sofran, because this can cause QT prolongation. The macrolide antibiotics, antifungals, antihistamines, methadone. If patients are receiving that as a concomitant treatment, this can result in QT prolongation. And the side effects associated with cancer therapy. Our patients may have nausea and vomiting, dehydration, followed by electrolyte imbalances like hypokalemia, hypomagnesemia, hypocalcemia, which can result also in QT prolongation. Now, the QT prolongation, it can be monitored by looking at the QTC on the electrocardiogram. So in managing this QT prolongation, based on, if patients are receiving any of those anti-cancer agents as well as concomitant treatments, which I previously mentioned, one is patients need to have a baseline EKG before starting the therapy. A QTC measurement is necessary and be recorded. The normal QTC ranges from 350 to 450 milliseconds for adult men and from 360 to 460 milliseconds for adult women. However, it has to be considered that 10% to 20% of otherwise healthy persons may have QTC values outside this range. Therefore, a baseline EKG measurement is really important in these patients. Why QTC? There's the QT interval and there's the QTC. The normal QT interval is 0.35 to 0.45 seconds. However, what we use in the management of these patients is the QTC because the QTC is critical, when patients have tachycardia or bradycardia, because the QT by itself is affected when there is these bradycardia or tachycardia. So the QTC is the best measurement for monitoring these QTC prolongation. So the second in terms of the management is the QT prolongation is like checking the electrolytes, particularly the magnesium and potassium. If abnormal, replete to normal levels because this can, especially magnesium, if you have hypomagnesemia, it can prolong the QTC measurement. If the baseline QTC is greater than 500 milliseconds or the patient has a history of QT prolongation of congenital long QT, then consult the cardiology. If the QTC, in starting the medication, is within normal, then you can start the medication. But monitor the electrocardiogram at 1 week and after any dose modification. If the QTC is greater than 450 to 480 milliseconds, adjust the electrolyte levels or make sure the electrolytes are within normal limits. And if it is greater than 500 milliseconds, or a QTC prolongation greater than 60 milliseconds from baseline, then it has to be discussed with the oncologist and the cardiologist for potential therapy discontinuation until the QTC level is back to normal. So why is this QTC important or monitoring important? Because if the QTC is prolonged, it can lead to the development of dorsodipone, which is like a ventricular fibrillation, or the twisting of points on the EKG, and it could result into the patient having a ventricular fibrillation and code. So that's why it's important to monitor those. So I think those are the most common potential complications that are symptoms, as well as the signs that I have for discussion.
Wonderful. Well, thank you for such a thorough and comprehensive overview. I feel like I've just gone back to school, and I think our listeners will find that overview very valuable. It makes me realize how in oncology we get so focused on all the variety of terrible symptoms that we have to help our patients work through. But for me, I don't know that the cardiovascular side effects are always the ones that are the most prominent or that rise to the top of my attention. And so your very detailed explanation of all the different agents that can cause these side effects and things to watch for just reinforces to me how this does still need to be top of the list, especially because of the severity of outcomes if these conditions do occur. I think you did a great job of emphasizing the importance of having that collaborative partnership with the patient's primary care physician or their cardiology specialist, especially if they have pre-existing conditions or comorbidities that they come into their care for their cancer diagnosis. We have to approach management of these issues as a team. That's so important for nurses to keep in mind that if these symptoms do arise, certainly the treating oncologist needs to be made aware, but treating them might be more of a collaborative approach with those other specialists when needed. Those are some important things to keep in mind. So thank you for bringing those to our attention.
Thank you for that comment, Jamie. I'm a cardiovascular nurse by background, and I am so enthusiastic when I came to MD Anderson in the oncology unit. I have to learn it, but I see the importance, as you have said, and I always say it's the heart of the matter.
That's right. Absolutely. As our treatments are getting more complex, you mentioned the myocarditis and just how our immune therapies are changing the symptoms that we're seeing or the side effects that we're seeing. I think a gut instinct for many nurses will be, oh, well, if they're getting anthracyclines, then we have to check for heart failure and the ejection fraction. Some of those things are long in our history of what to watch for. But some of these newer symptoms as they develop and changing, and as you mentioned again, the hypertension and some of our targeted therapies is just creating a different landscape of what needs to come to our minds as oncology nurses. It's really every possible cardiac symptom, it seems like, could potentially be caused by the treatment that we're giving or the disease that they have, depending on where that is presenting in the body. So it's become much more, I think, complex. And I think this is going to be a great episode to help bring this back to the attention and the forefront for our oncology listeners.
Thank you for that comment, Jamie.
You've already highlighted in a great way, but what we can see from the descriptions that you've given is that a lot of these cardiovascular complications can overlap, and the symptoms may look the same, but be ultimately different kind of causes, or at the end of it all might be different syndromes that we're dealing with. So can you explain a little bit more about which of these complications do have those overlapping symptoms and what do they look like?
That's why, cardio-oncology is more complex than the straightforward cardiology practice. Because in terms of the cardiovascular complications, these symptoms, as you have mentioned, can overlap. But on the other hand, it's a very interesting area of practice too, because especially as a nurse, it's like you are like a detective looking into the case and trying to find out what is the main etiology. So, and for example, I talked about chest pain. That's a very common symptom, which when you are presented with that patient with chest pains, then you'll say, you cannot just jump right away and say, oh yeah, it's a heart attack or an acute coronary syndrome. In a patient with cancer, as I mentioned earlier, myocarditis has increased indications now. And one of the complications of immune checkpoint inhibitors, one of the side effects is myocarditis. So the overlapping symptom I would like to discuss here is like chest pain. Most often, chest pain is the presenting symptom in these cardiovascular complications. And chest pain per se, in a patient without cancer, first thing comes to mind is the acute coronary syndrome. And it's not that in a patient with cancer, you think that, from the cardiology standpoint, we think of the heart first. But a chest pain the overlapping symptom for patients with acute coronary syndromes, patients with myocarditis, pericarditis, pericardial effusion, endocarditis in patients with valvular disease. So when patients having chest pains in myocarditis, when you see this in the clinical area, patients with myocarditis can seem like having a heart attack. And as I mentioned earlier, the incidence of myocarditis in patients treated with immune checkpoint inhibitors is like about 0.4% to 1.14%. I always think of it as less than 1%, but it carries a high mortality rate of 25% to 50%. And in the patients with myocarditis, the median time frame from the start of the ICI therapy to presentation is about 17 to 34 days. So in terms of these chest pain, let's talk about the immune checkpoint inhibitors here. It can vary from just a mild chest pain to a severe chest pain. And it is also graded, like grade 1 is typically asymptomatic. But then you'll say chest pain, the symptom is because patients will present with an abnormal cardiac biomarker, or you can see some changes in the EKG. In the grade 2, they have mild symptoms in addition to an abnormal cardiac biomarker or an abnormal EKG. And then in grade 3, there's moderate in intensity, and the transthoracic echocardiogram may show a decreased EF, ejection fraction, which may be less than 50%, or there's regional wall motion abnormalities. Patients in this case, most often, to delineate or rule out the cause of chest pains is a cardiac MRI or a cardiac magnetic resonance imaging, which will confirm the diagnosis of myocarditis. And grade 4, in the ICI myocarditis, the symptom is severe with a life-threatening disease. And it will include the abnormalities which I mentioned in grades 1 to 3. So in looking at this, symptoms, it can mimic, the chest pain can mimic acute coronary syndromes. And as I mentioned, myocarditis, pericardial effusion, and valvular disease. The other one that is like most common also is in patients with shortness of breath. Shortness of breath, when you look at these patients, the first thing when you look at shortness of breath, usually the other service would refer to cardiology because they will think it's heart failure right away, part or heart failure. But then if you think of it, it can mimic the symptoms related to other complications, such as if the patient's pulmonary embolus, if the patient has a history of lung cancer or breast cancer that has metastasis to the lungs and have shortness of breath. So identification of symptoms is important in terms of managing these patients. However, when a patient presents with symptoms, they can overlap over other disease conditions, and it has to be ruled out and a definitive diagnosis should be given so that a definitive therapy for a specific condition can be initiated.
You mentioned briefly, but are there other diseases that cancer therapy, cardiovascular complications might mimic?
Yes. In terms of the myocarditis, as I said, chest pain syndrome can mimic acute coronary syndromes, but it can also, the symptoms that are shown in patients with myocarditis, can mimic myositis, myasthenia gravis, and, these symptoms can occur early or late in the disease process. And it can also be associated with arrhythmias and conduction disturbances. Now, in terms of myositis, with chest pains or, like chest pain and myasthenia gravis, the differential is like in myositis and myasthenia gravis, without cardiac symptoms, may be an early indication of a systemic inflammation. And it raised the suspicion of myocarditis. In one of the studies, in 180 cases of patients with ICI-related myositis, myocarditis was diagnosed in 16% of cases. So which means that, the symptoms are the same, but it's not really, what you think, like patients with myocarditis, specifically when these patients are receiving immune checkpoint inhibitors. So when they have chest pain, it is like ACS or myocarditis, but, you have to rule out these associated, like side effects which may be because of the T cell involvement.
So as a nurse who's caring for a patient who, maybe is getting some of the agents that you mentioned specifically that we know have an associated risk with some of these cardiovascular symptoms, how should a nurse assess for and monitor these treatment-related cardiovascular complications when caring for their patients, both if it's an acute setting, if they're an inpatient, or even if they're receiving a treatment in the outpatient setting over a long extended period of time?
Thank you for asking that question, because I always believe that the nurses have a critical role in identification, monitoring, and management of these treatment-related cardiovascular complications, both in the inpatient setting and the outpatient setting with our cancer survivors. So a nurse, should remember that in nursing practice, before administering anti-cancer treatments, which are potentially cardiotoxic and known to have a cardiotoxicity adverse effect, a comprehensive cardiovascular history and a full cardiovascular assessment should be performed. In this review, with the baseline assessment, they should include review of the cardiac risk factors, such as hypertension, hyperlipidemia, diabetes, obesity, which are very common in our adult patients who are diagnosed with cancer. Also review the current medical regimen, what are the medications, are they taking, any of those medications and cause QT prolongation? Or are they optimized in terms of controlling their blood pressure? Also, because of the increased survivorship, the nurse should also review a prior history of cancer therapy in these patients if applicable. Because if they present with those symptoms, it will help you with notifying the physician to do a further workup. Like, for example, in breast cancer, or a survivor, if a patient has received anthracyclines before, remember that left ventricular dysfunction or cardiomyopathy or heart failure can occur way after the treatment is finished. In my experience, as long as like 30 years after they're out from the cancer treatment, and then they present with signs and symptoms of heart failure. And this is not to say that it is just plainly secondary to anthracyclines, but because of the increase in age and the presence of other comorbidities, like patients may develop that. So it is really important that a comprehensive cardiovascular history and a full cardiovascular assessment should be performed. Another one is nurses should look at the baseline diagnostic tests, specifically based on the type of anti-cancer treatment planned or performed, which the adverse effects I mentioned previously. For example, a patient who is planned to receive anthracyclines or HER2 therapy should have a baseline echocardiogram to determine a baseline left ventricular ejection fraction, or EF. Another example is patients are planned to receive ibrutinib, or other tyrosine kinase inhibitors, should have a baseline EKG because, they can potentially develop atrial fibrillation. Or those patients who will potentially receive anti-cancer agents that could cause QT prolongation, a baseline EKG should be performed. Also, as I mentioned, besides a diagnostic test, a cardiac workup can include, besides the echocardiography, chest x-ray, cardiac biomarkers, especially with patients with signs and symptoms. The cardiac biomarker I'm talking about is like troponin as well as the BNP, or B-type natriuretic peptide. And this basic cardiac workup is recommended by the American Society of Clinical Oncology for the management of ICI myocarditis. And in certain cases, if coronary artery disease is suspected in patients who are planned to receive an immune checkpoint inhibitor, that has to be ruled out, meaning the severity of that coronary artery disease. A myocardial perfusion stress test may be done, or a coronary angiography or a cardiac cath should be performed prior to patients receiving the ICI. It is important that these has to be managed first because it is difficult or a challenge to manage when these cardiac complications occur while patient is receiving these immune checkpoint inhibitors. And so, like I mentioned earlier, in terms of the diagnostic tests, I mentioned troponin level, should have a baseline so that you will see the trends. In myocarditis, because we have been talking about it, a cardiac MRI, can be performed because not all patients will have an endomyocardial biopsy, which is invasive. So cardiac MRI now can confirm a diagnosis of myocarditis. It's recommended because nearly 50% of patients with increased symptom serum troponin, which will be elevated in acute coronary syndromes, showed no evidence of systolic dysfunction. And that's interesting because in patients with myocarditis secondary to immune checkpoint inhibitors, like they may have shortness of breath also in addition to the chest pains. But not all patients with shortness of breath secondary to myocarditis will have a decreased left ventricular ejection fraction. Sometimes, they have a normal EF. They will have the signs and symptoms of somebody having a heart failure. So those are, I think, the critical role of nurses in the management of this patient.
And I think you've done a great job of just emphasizing, as an oncology nurse, it is that role of being proactive. So knowing not only what your patient's current cardiovascular status is, if they have any pre-existing conditions, knowing the therapy they're going to be put on, what risks does that present to them based on what we know the side effect profile to be, and then also understanding, what baseline information is critical to collect before we start them on a therapy so that we have something to compare some of that objective data to. So if they do have symptoms, especially that overlap over a variety of conditions, it might be really critical to have certain baseline data collected, whether that's, as you mentioned, baseline echocardiograms or EKGs, just so that we can then reflect back and see, okay, what changed since we started this therapy? So that's really some great information for nurses to consider as they are doing some of those initial assessments and starting patients on treatment for the first time. So thank you for sharing that.
In addition, Jamie, I'd like to make a comment that when I have to draw the interdisciplinary team, intercollaborative team for the management of cardio-oncology patients, I always place nurses in the center of it besides the patient, because nurses are the eyes and the ears of the multidisciplinary care who is seeing the patient 24 hours a day. And early recognition, nurses can do it and monitor, the response and all the other symptoms.
Absolutely. So as the symptoms potentially show up or progress and complications then result from these therapies, what are some of the typical treatment recommendations for these cardiovascular complications?
Given those different cardiovascular complications, the treatments for each of those currently is based on recommendations from clinical guidelines of professional organizations. Given that cardio-oncology is an evolving specialty, it's a young specialty, so there are still a lot of studies that needs to be done, to be definitive of the treatments that is specific for this patient population, because there's still a lot of studies ongoing. But as of now, the recommendations are based from the clinical guidelines of professional organizations.
Well, and that's very exciting just to hear, as a new specialty, how there already is that collaboration with the established organizations and, guidelines that are already in place, but knowing that they're, as you said, ongoing, the need for and the continuation of more research to understand, would those guidelines need to be changed or altered at all because of the relationship to the oncology treatment they're receiving or the diagnosis that they have. So sounds like we just need to keep our ears open for the newest information that comes out as the research progresses. As we've talked about a little bit with patients who certainly come into the oncology setting with typically other diagnoses or comorbidities that come along with just an aging population, are there any considerations that you would recommend for nurses to talk with their patients about who maybe have a baseline cardiovascular disease prior to starting their cancer therapy? And how can they talk to those patients about if their risk is increased for these treatment-related cardiovascular complications?
Yeah, as I mentioned, nurses are very critical in the management of these patients. And we nurses are the experts in terms of doing patient teaching, because we have an intimate relationship with patients. In terms of the baseline cardiovascular disease, in terms of patient teaching, it is very important, for nurses to teach the patient aggressive management of the known cardiac risk factors, such as I mentioned, hypertension, hyperlipidemia, and diabetes, because these are the ones that could cause cardiovascular complications later on when patients are receiving anti-cancer treatments and weigh into cancer survivorship. They have to educate patients in terms of what are the guidelines, meaning in terms of hypertension, what's the target number? Because sometimes, like I've seen this in clinical practice, wherein patients who are just diagnosed with cancer and are coming to the cancer center for cancer treatment. And at baseline assessment, in order to, or the pre-chemo or the pre-surgical evaluation, patients with a known hypertension are not controlled. And it is not the patient's fault because they have seen their primary care physician. They are on blood pressure medications, but it is not controlled. Therefore, when you expose them or you do a stress testing on these patients, the blood pressure would go sky high. Therefore, they cannot finish the stress test, and you have to optimize these management first before the patient can proceed with a cancer treatment or surgery. So, as nurses, it is important to emphasize to patients, what are the recommended parameters in controlling the blood pressure? Because patients, hypertension, as you know, is, unless patient go into stroke, it's asymptomatic. Like their blood pressure may be high, but their medications are not optimized. As nurses, we need to take a look at that and reinforce this in patient care as well as for them to take their medications. And sometimes patients won't take their medications because, they don't have any symptoms. And meaning, specifically, I'm talking about hypertension and hyperlipidemia. They don't have any symptoms until they go into these end organ damage or, secondary effects because of uncontrolled hypertension or uncontrolled hyperlipidemia. Another one is like in patients, well, one of the things that it is difficult sometimes for patients is like patients who are smokers. Of course, reinforce teaching, to stop smoking because smoking has a negative impact both from the cardiovascular standpoint as well as from the cancer standpoint. So these are the things that nurses would need to recommend or encourage in patients, as well as, I forgot, the active lifestyle and the dietary management, like in short, the heart healthy habits that patients should have. And sometimes it's overlooked, in a cancer patient when they first started, it's because the focus, is to treat the cancer, which rightly so. That's how it should be. But not forgetting that the heart is there that will help, in terms of curing the cancer as well as improving the patient's quality of life.
I think you're absolutely right. And your statement made me kind of take mine back because sometimes you're right. Patients will either they've had, a diagnosis maybe of hypertension or hyperlipidemia, and it's just, they don't maybe give it as much attention as they should. So it's not optimized. And sometimes patients have not been able to access care. And so their cancer diagnosis is what finally brings them into the healthcare system. And so that might be the time that we are actually uncovering some of these other factors. And as you mentioned, if they're not managed and controlled and optimized, then that can interfere with starting their cancer therapy, whether it is their surgery that needs to happen first and their, pre-admission testing says they're not safe for surgery until we can work these things out, or chemotherapy, other agents that have very strict guidelines on what blood pressure has to be if we're going to be able to administer that therapy. So, what a great message of nurses and how they have to continue to be the champion for that patient and encourage them that while, as you said, sometimes it's easy to put blinders on and think about only treating the cancer and getting cancer therapy, you can't forget about the other things because they can actually delay or prohibit us from moving forward with that until those other things are optimized. So what a great message.
Thank you for reinforcing that.
Well, Anecita, you have taught me a bunch today, and I'm going to have to listen to this episode on repeat to get it all in. But thank you so much for what you've shared with us today. At the end of our episodes, we like to do just a few wrap-up questions just to help hit that message home. And so our first question is, what are some common misconceptions about cancer treatment-related cardiovascular complications?
There are quite a few misconceptions in terms of these treatment-related cardiovascular complications. Sometimes it's overlooked, when the cancer treatment-related cardiovascular complications, I've noticed, are often minimized in the conversation when cancer treatments are discussed with patients and their families. I said that because many patients that are coming to the cardiology clinic, or I'm following up in the cardiology clinic, states that they are not aware of these complications when they were given instructions regarding their cancer treatments. I think they may have some validity to it, or in certain cases, patients, when they present with cancer, are so stressed out that they do not hear other things accept, their cancer because it's a very stressful diagnosis. However, it can be, as we mentioned earlier, nurses should reinforce those cancer treatments. Another thing too is like when patients are getting cancer treatments, the main goal, as I mentioned earlier, is to cure cancer, and rightly so in this diagnosis. But patients should be aware of the cardiac complications to make a well informed decision about their treatment. Sometimes, they're saying, like, well, no, the heart, it's placed on the back end, yes, because I do not know if they're saying it's not going to happen, but they want to treat the cancer. But in the long run, especially when they become survivors, it is a big issue, if it's not discussed in the front end.
What's something about this topic that's not often discussed, but you wish more people knew about?
About this one, we talk about the cardiovascular complications, but I wish that people are more aware of the prevention of cardiovascular disease, particularly in the awareness of the management of the cardiovascular risk factors, especially, I mentioned those, I pounding on it, hypertension, hyperlipidemia, diabetes, obesity, because this is important not only in patients with cancer and cancer survivors, but in the general population as well. As we all know, cardiovascular disease and cancer are the leading causes of death in this country. It's not often, this emphasized, these cardiovascular risk factors. But I think, people should be aware of that because, as I mentioned, they were asymptomatic in the early stage, but it's being paid attention when it's already in the end organ damage. So people should know more about it and discuss it. And as I said, not just in patients with cancer and cancer survivors, but in the general population as well.
What additional training or education do oncology nurses need to understand and address treatment-related cardiovascular complications?
Cardio-oncology nursing, as we know it, is still in its infancy, and it's not a part of the nursing curriculum. However, as I mentioned, given that heart disease and cancer are the leading causes of death in this country, and the statistics showing increasing incidence of some types of cancer, as well as increasing survivorship, nurses should have at least a basic understanding of cancer treatment related cardiovascular complications. Currently, there are some resources that nurses, particularly oncology and cardiology nurses, can learn more about the topic. And some of these, are like one, the educational conferences on cardio-oncology offered by specialty organizations, including the Oncology Nursing Society, the American College of Cardiology, and the Heart Failure Society, and the International Cardio-Oncology Society. This is an advertisement, shameless advertisement. At MD Anderson Cancer Center, we have the Cardio-Oncology Multidisciplinary Practice, or COMP in short, 2023 conference that is coming up on February 13, 2023. It is a virtual conference with 7.5 contact hours of CEU credit, including pharmacology credit hours. This is nursing focused, and the presenters are advanced practice nurses and bedside nurses, as well as some cardiologists. That is given at the basic level as well as the high points for understanding how these patients are managed. If anybody's interested attending this, let me know and I will send you the info. Another resource is the American College of Cardiology, Advancing the Cardiac Care of the Oncology Patient Conference. And this is done in Washington, D.C. in the summer every year. And the next one is going to be on April 14 to 16, 2023 in the Hart House in Washington, D.C. Another one resource is the ONS Congress, which will be in April 26 to 30 in San Antonio, Texas. And I will have some topics on cardio-oncology. And the other resource is the GCOS, or the Global Cardio-Oncology Summit 2023, which will be on September 27 to 30, 2023 in Madrid. So if anybody wants to go to Madrid, then, let me know and I will forward to you the info. So far, there are others besides these that I have mentioned. And, if you are interested, you Google, a cardio-oncology nursing conference or stuff like that, and it will give you those websites or inputs. Another thing too is there are like web links for all these conferences I'm talking about, and it's linked to the organization. And they have a page that will have some video, like for example, the ICOS, or International Cardio-Oncology Society. If you log into their website, you have a lot of audio and video conferencing related to cardio-oncology topics.
Well, wonderful. And we'll be sure to include many of those links in the episode notes for our podcast today. Thank you so much for all the wonderful wealth of information you've shared with us, Anecita. Do you have any final comments to share with our listeners?
Well, thank you for the opportunity to share with you some of the information about the cardiovascular complications of cancer therapy. The new specialty, cardio-oncology, is a team sport when I look at it. And nurses play a key role in the management of these patients. Working together in an interdisciplinary approach will result in the best outcomes for our patients. And nursing or nurses has the key into this interdisciplinary team.
Thank you so much for your time today. And I encourage all of our listeners to, look at your own institution and find out, do you have a cardio-oncology program? Is one forming? Is one growing? And contribute. So thank you for sharing your information with us today.
Thank you for inviting me and share these thoughts on the management and the role of nursing in cardio-oncology. Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.